Hello, Ashray. Are we live? Can we start? Okay. So, good evening, everyone. Welcome to another session of ophthalmology and a clinical class, that is comprehensive clinical class. Due to technical reasons, as we all know, that there was a storm in Chennai, we couldn't connect to Rajaratna Thangavel Madam today. We are very sorry for the inconvenience caused. However, we have with us today Dr.Akshatha Prakash ma'am, who's a cornea fellow from Minto Eye Hospital, who's agreed to moderate today's session at such a short notice. Thank you very much, ma'am. As a presenter today, we have first year PG from MIMS Mandya, Miss Dr.Raksha A. Kini, who will be presenting a case on corneal ulcer. So it is going to be at a little bit higher level, that is at a first year PG level. But I'm sure all the UGs will understand the disease better. It will help you get an overview of the disease per se and how it is managed. So please utilize this session and make the best use of it. Over to the mentor and the presentee.
Thank you, ma'am. Can I start?
Yeah, you can start.
Okay. So this patient named Mr. Giriai, who is 65-year-old, farmer by occupation, hailing from Mandya, Karnataka, was admitted on 10th of October 2020 and discharged on 13th of October 2020. He came with the chief complaints of pain in the left eye since 1 week, redness since 1 week in the left eye, and diminution of vision on the left eye since last 1 week. History of presenting illness. Patient was apparently all right 1 week ago, after which he developed pain in the left eye, which was of sudden and onset to the left eye, associated with redness, which was also insidious in onset, rapidly progressive. Diminution of vision was also insidious in onset, rapidly progressive, and complained of diminution of both distinct as well as near vision. History of watering, photophobia were also present. It was not associated with any other discharge. Patient denies any history of trauma. History of previous ocular surgery was present. There was no history of usage of contact lenses. No previous episode of watering or discharge from the eyes. No history of application of chronic topical medications. No history of watering of eye, burning of or rubbing of eyes previously. No history of HIV or any transplant history, malignancy, or immunosuppressive treatment. No history of diabetes mellitus or hypertension. No history of joint pain, back pain, connective tissue disease, and no similar diseases in the past. Past illness, a family history, and personal history. He had no significant past history, no history of diabetes mellitus, hypertension, tuberculosis, asthma, or epilepsy. No relevant family history. Patient consumed mixed diet. His bowel was normal, bowel and bladder was normal and regular. Sleep was slightly disturbed, mainly due to the pain, and appetite was normal. Examination. Patient was conscious, cooperative, and well-oriented to time, place, and person. He was moderately built and poorly nourished. His pulse rate was 84 beats per minute, which was regular in rate, rhythm, and volume. Patient was afebrile. Respiratory rate was 16 cycles per minute, regular. Blood pressure was 110/70 millimeters of mercury, checked in right arm supine position. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema were all absent. Systemic examination, CNS, there were no abnormalities detected. Respiratory system, normal vesicular breath sounds were present, no added sounds. CVS S1 and S2 was heard, no murmurs. Per abdomen was soft, non-tender, and no organomegaly. Coming to local examination, head posture was normal, with visual axis being parallel to the sagittal plane. Facial symmetry was normal, and forehead was normal. On examination, I'll start with the left eye first. Eyebrows was at the same level as that of the right eye. Eyeball position was orthophoric, alignment was normal. Extraocular movements were full and adequate in all directions. Lid position was normal. Margins were edematous. Eyelashes and skin around the lid was normal. Palpebral width was 25 millimeters, whereas height was reduced to 7 millimeters. Lacrimal apparatus, puncta apparatus was visible, everted. Sac was normal. Syringing, it was patent. Conjunctiva, superficial and ciliary congestion, circumciliary congestion was there. Circumcorneal congestion was present. Upper and lower palpebral conjunctiva were congested, and medial phonacial congestion was present. Coming to cornea, vertically cornea size was around 11.3.9 millimeters. These were normal but irregular. Transparency, there was diffuse haziness of the entire cornea. Sheen was absent. Corneal thinning with iris plaster to the cornea. Infiltrate was measuring around a 6 into 6 mm size. Epithelial defect was 5 into 5 millimeters size. Descending membrane folds with corneal edema was present, and there was vascularization of cornea. Corneal sensation was intact in all the quadrants. That is the image of the ulcer, which was centrally located. Hypopyon of 1 millimeter height was present. Epithelial defect of 5 into 5 mm. There was thinning of cornea with iris being plastered to the epithelium. Infiltrate was 6 into 6 mm. Hazy cornea, DMFs with corneal edema was present. Anterior chamber couldn't be made out due to the haziness, but hypopyon was present, which was 1 millimeter size. Iris details couldn't be made out. Pupil detail number size position couldn't be able to make out due to the haziness. Lens unable to visualize. Disc and macula unable to assess. Digital tonometry was slightly harder than the right eye. Visual acuity, distinct vision was counting finger 1 meter. Summary. A 65-year-old farmer by occupation. General, there's no comorbidities, no history of smoking or consumption of alcohol. Chief complaints, there was pain and redness and diminution of vision over the left eye. Duration since last 1 week. Causative factor could be trauma, though the patient denied any history of trauma. It was rapidly progressive. On examination, lid margins were edematous. Palpebral height was 7 millimeters. These are positive findings. Conjunctiva, circumcorneal congestion was present. Corneal congestion, palpebral conjunctiva was congested. Cornea, diffuse haze, corneal thinning with iris plaster to the cornea. This size. Epithelial defect was 5 into 5 mm size. DMFs with corneal edema and vascularization was present.
Okay.
Investigations. Routine investigations with CBC, PS, ESR, RBS, FPS, PPBS, HbA1c, everything was within normal limits. Microbiological examination. Corneal scraping was sent for gram staining as well as KOH mounting. Gram staining showed gram-positive cocci. KOH mounting, no fungal elements were seen. Management, patient was conservatively managed. Therapeutic scraping was done. Fortified zone eye drops was given early. Netamate eye drops was given early. Homide was given early. Timolol was given BD. Doxycycline 100 mg was given BD and Rantac BD. And diagnosis could be bacterial corneal ulcer, mostly Staph aureus being the infective organism.
Okay, Raksha.
Yes,
Coming back to your first slide.
Okay, ma'am.
Yeah. So you say the occupation is farmer. Okay.
Okay,
And
ma'am.
he's hailing from Mandya. So I just want to know, just for my own knowledge, is this a virtual case or an actual case?
This is the actual case, ma'am.
Okay, actual. Okay, I believe. So what do you suspect, like most common eye condition in this occupation?
Ma'am, could be and vegetative injury to the eye.
No, but just as a farmer, if he's coming to an
Okay.
ophthalmological OPD, if you're
Okay.
sitting in an OPD and if somebody comes with just being, saying he's a farmer, what is the most common finding you see in them? What are the
Pterygium.
possible, pterygium and age
Any
also?
a cataract also, ma'am.
Yeah.
Due to age.
Aging is one thing. Farmer, UV light is
Ma'am, I
exposed.
didn't.
Hello.
Yes, ma'am. I can hear you now.
Yeah. So you can come from the conjunctiva up to the retina. Okay. In
Okay, ma'am.
conjunctiva, you said pterygium.
Okay.
Then in cornea, you have your ulcer.
Ulcer.
What else? You said cataract. Very good. What is the explanation for it?
Ma'am, age could be one of the factors.
Okay, but he's farmer. No, I'm asking in particular why.
Any trauma, ma'am?
No, trauma. It is not a must. Okay, trauma. But
Okay.
yeah, UV rays. Somebody has written Neha. Yes. So UV rays is known to
Progress down.
enhance nuclear sclerosis, aging.
Yes.
So
Okay.
that's why he will even present with cataract. So coming to your basic details, I assume like it could be any of these. So to your next slide.
Pain since 1 week, redness and diminution of vision.
Okay, what are the possible differentials in this?
Pain and redness could be due to any ulcer.
No, what are your differentials for pain, redness, and diminution of vision?
Ma'am, glaucoma.
Glaucoma is a very vague term.
Acute.
3 differentials. Give me 3 differentials for this diagnosis, for your chief complaints.
Ma'am, any ulcer, acute angle closure glaucoma.
Yeah.
Any traumatic, ma'am.
Conjunctivitis.
Conjunctivitis.
Somebody is written in the chat conjunctivitis. I'm not able to open both simultaneously. But yes, conjunctivitis, acute angle closure glaucoma, and your corneal ulcer. All these are acute conditions. That is why they have pain, redness, and diminution of vision. Now we have to differentiate the 3. If these 3 are your differentials, how do you differentiate? Is there anything to differentiate between these 3? I mean, amongst these 3?
Ma'am, any history of trauma?
Trauma can be there, cannot be there. No, in your ulcer only, there is no trauma.
Okay.
What are the things? How will you differentiate?
Just by the history, ma'am?
No, anything. It can be even your examination, any special test, anything.
Ma'am, IOP.
Okay, it is elevated in your acute angle closure glaucoma. Then?
Diminution of vision is less in conjunctivitis, ma'am.
You can't quantify. See, if the ulcer is in the initial stage, he will have it less only. Okay. If it is not central, then also he will have less diminution only. But how will you, is there any standardized standardization of diminution of vision? Like it is severe, mild, moderate? No. Just the complaint that the patient has. It's all subjective. Anything? So by somebody has written that glaucoma and uveitis. So a glaucoma, by here you mean acute congestive glaucoma, has circumcorneal congestion, and conjunctivitis has more of your conjunctival congestion, like palpebra and all. Even your corneal ulcer will have circumcorneal only, ciliary or circumcorneal. Okay, uveitis we have not included in this because I'll tell you why. Now, what is the special test you do to differentiate between these three, amongst these three? In ophthalmology, you would have read it in your UG. What is Fincham test? Anybody in the chat? What do you do in your Fincham test?
Not very sure.
Okay, you go and read up about it. It's a slit, okay? That is to differentiate your conjunctivitis, acute congestive glaucoma. In both the cases, you will have breaking of the slit. But in what I've told you repeatedly, as in the previous classes also, so please read about it. You will have a special complaint called colored halos. Very good, somebody has written it. So this is also one. Yeah, very good. And what happens in conjunctivitis? People have written it in the chat.
Colored halos are present, ma'am.
Yeah, colored halos will be present, but how will you differentiate? That Fincham test is to
The
differentiate.
break, it's continuous and it's like there's a breaking of it.
Yeah, where will it break? Where will it be intact? And what is the reason behind it? Go read up about it, okay?
Okay, ma'am.
Yeah. Yeah, so, people are writing. People can keep writing in the chat box. We will discuss it. You can proceed with your HOPI.
My patient was apparently all right 1 week ago, after which he developed.
So you say it is sudden in onset, okay? 1 week is sudden in onset, after which he developed pain and it was progressive. So it was only confined to left eye.
Yes.
Was it increasing or decreasing the pain? You've not mentioned any aggravating, relieving factors?
No aggravating and relieving factors, ma'am.
You should mention that.
Kept in. Okay.
You have not said anything about that. Then any diurnal variation?
No, ma'am.
You should mention that. No, where is it?
Okay.
Your pain, if it is associated with any diurnal variation, what does it suggest of?
Glaucoma could be.
Yeah, so in glaucoma, what happens?
There is change.
There's a diurnal variation of eye. So in the morning and in the evening, there is a peak.
Yes.
So that is when there is a increase in the pain in both morning around 11 and 7, around 7 in the evening. So according to the variation in the IOP, there is variation of pain. Here you don't have. So you have to rule out. If you just say pain,
okay,
it should be, so you say there are no aggravating and relieving factors also. So anything that will aggravate or relieve in eye pain that you know of? If at all he is on any medication, the pain will be temporarily reduced.
Yes, okay.
Okay, if he is not, then yes. And in case, if on movements also. So it could be anything. It could be orbital cellulitis, anything. See, all those are your differential. So on movement, you've written on movement, no?
No, I have not mentioned about it, ma'am. But
so everything should
not any particular aggravating or relieving factors, or on movement of eye there was no change. It was present throughout the day.
Yeah.
Okay.
There is no diurnal variation. Okay.
No.
And then you say it is associated with redness. That was also insidious. Okay, sudden in onset, no?
Yes, ma'am.
1 week, you don't say insidious because they'll remember. If it is 1 month, once it is insidious, they don't remember. Insidious indicates chronicity.
Okay, ma'am.
Okay, so it was rapidly progressive. So, okay. Was there any discharge? You said watering.
Watering was present, ma'am, but no mucoid, no mucopurulent discharge, nothing like that.
Okay, so no discharge. And you don't say photophobia. What do you use in your history?
Glare.
What is photophobia?
inability to look towards the light.
It's just
Difficulty.
inability. Ah,
Difficulty.
okay. And you say there is diminution of vision. So coming to your
Yes.
diminution, that is
Hmm.
also sudden in onset, not insidious. 1 week he remembers, no? Insidious is he doesn't remember
Yes.
at all. Okay. Then it is
Okay.
rapidly progressive, you said. So I'm thinking it could be central, like how you mentioned in your examination. And you say it is for both distance and near vision. What does it say? Anything in particular you want to rule out?
Yes.
Why you're saying both distance and near?
Yes, ma'am. Yes, ma'am.
What are you ruling out?
Ma'am, cataract. Ulcer was central. That's why his vision was deteriorating both in distinct and near. Whereas
In peripheral, what will happen?
the near vision will still be okay, ma'am.
How will you explain that? No, it is not like that. What exactly are you ruling out by saying it is both distance and near, not only distance or not only near? There are two for your differentials that you're ruling out here.
Okay.
Yeah, in second
Then-
slide, somebody is saying cataract and glaucoma, correct. So what happens in cataract? If it is nuclear sclerosis, there is index myopia.
Yes, ma'am.
So
They
what
can
will
see
happen? Your near vision will actually improve. So the patient will only
better.
have blurring of distance
Yes.
vision.
Distinct vision goes over.
Yeah. So in that you are saying you're ruling out cataract in this, like at least nuclear sclerosis. Okay. And what happens in glaucoma?
Distinct vision is affected, ma'am, mainly.
In glaucoma, no. What
And
is
they have, they'll have peripheral vision is affected mainly.
that is end stage glaucoma, but what is the main complaint around 40 years? They'll come to your OPD with not glaucoma, but something else. What is that? Not acute
Scotoma.
congestive glaucoma. I'm saying
Okay.
the primary open angle glaucoma. What will happen to it? Somebody is saying, yes, Neha, correct, but what happens? What happens in glaucoma? So there's frequent change of presbyopic glasses.
Yes.
Yeah, frequent change of glasses, that is presbyopic. So your accommodation keeps altering.
Changing. Okay.
Yeah. So that way you've ruled out both the cases, both the causes of diminution of vision here. Okay. So you're saying something is in the cornea. We are not coming to ulcer yet. It could be what are the differentials at this point?
Ma'am, still could be glaucoma.
No, you ruled out, no? Glaucoma, your primary open angle is over. What glaucoma? You have to specify.
Acute angle closure glaucoma, ma'am.
That also you've ruled out partly. You said the
conjunctivitis still.
pain is not diurnal, no?
Yes, ma'am.
So that also you've ruled out. So what have you narrowed it to?
Ulcer and conjunctivitis, ma'am.
Yeah, it could be both ulcer or your conjunctivitis. Then next slide.
Not
Yeah, it is
associated
not
with
associated with discharge. Okay. Patient denies any history of trauma. Still okay. Why have you asked about ocular surgery?
Ma'am, any previous ocular surgery, they would be chronically using something like in glaucoma surgeries, using any topical medications.
So what will that cause?
Ma'am, any infective topical medication can precipitate an ulcer formation.
Infective topical medication. What infective topical medication do you prescribe?
No, like if it was
Like what?
in glaucoma patients, ma'am.
No, but what is that you prescribe and you're scared that it will cause ulcer?
A long usage of timolol.
So what will it cause?
Chronic usage would affect, ma'am.
Timolol will only cause probably your papillae or follicles. That's all. But why are
That
you
was
scared?
repeated trauma to the like papillae or anything for a chronic or like a long duration would
See, now you're
cause
saying
trauma to
ocular
the cornea.
surgery. Ocular surgery, how will it cause? I'm just asking you to rule out. You've written correct. History of previous ocular surgery. Okay. What you are saying, it is present.
Yes, ma'am.
What is
And
what?
it was a cataract surgery which was done later.
Okay, now how will you explain? Like anything?
Hmm.
Okay, you know or you don't? Not sure.
Not sure, ma'am.
Okay, so simple it is. It could be your any surface or anything affecting your cornea. See, it could be your LASIK surgery, refractive surgeries. Where you know no, there are chances of
Yes.
post LASIK infection also, which can lead to corneal ulcer and all. One is
Yes.
that. It could be as simple as your pterygium surgery, where there is encroachment of the pterygium into the cornea and you've shaved the corneal epithelium, you've debrided the epithelium, so you've left a raw surface. So any raw surface causing, as in any surgery that leaves a raw surface on the cornea, like you debrided the epithelium, that is the source of your infection. It need not be trauma always. It could be your these ocular surgeries is what it is. It could be your keratoplasty surgeries.
Okay.
They are more prone for you. You will see day in, day out, all these patients coming with suture tract infection, which leads to ulcer and everything. So
Yes.
basically your cornea and your pterygium surgery, anything that leaves a raw surface on the cornea without epithelium, that means it is not protected. So epithelium is your protective barrier.
Okay, ma'am.
Okay, cataract surgery is unlikely until unless you have left a major epithelial defect where it is not healing and it is secondarily infected. Then I can agree. Okay.
Okay, ma'am.
Yeah. And you say no history of usage of contact lenses. Why?
Ma'am, like contact lens, whereas usually could be infected with Pseudomonas.
What exactly? What are you?
The solution, ma'am. The solution, the homemade solution.
Homemade solution you're not supposed to use. Anything else? People are saying Pseudomonas is one.
Acanthamoeba.
Acanthamoeba. So these keratitis are more common in contact lens users. Okay. The solution can be infected, or they could have used unsterile hands without washing properly. Anything, the container could be infected, anything could be. Okay.
Yes, ma'am.
So how do you explain in these patients, how will it cause, like contact lens, how will it cause keratitis? It is totally different.
Because of dry eye, chronic usage of contact lenses can cause dry eye, ma'am.
Okay, then.
And because of the solution.
Okay, ma. Okay, agreed. But your epithelium is still intact. It can cause conjunctivitis. Why is it causing keratitis?
Ma'am, hypoxia.
Contact lens users will mostly present with conjunctivitis, frequent. It is a very common problem. But in special cases, you will have keratitis, and the organisms associated are Pseudomonas and Acanthamoeba. But how?
Acanthamoeba. Ma'am, because of the hypoxic condition, which is.
Can Pseudomonas penetrate intact corneal epithelium?
Yes, ma'am. Yes.
Pseudomonas can penetrate, you're saying.
Hello?
What are the organisms that are...
Yes.
Now coming back to one question, what are the organisms that can penetrate intact corneal epithelium?
Ma'am, Neisseria.
Neisseria.
Meningitis and con.
Yeah.
Hemophilus. Hemophilus can.
Yeah, correct.
Pseudomonas.
Pseudomonas is not. That is why I'm asking.
Okay.
The other two? Okay, I will expect it in the chat box. If people can. Listeria, yes, correct. Cornybacterium, they have given it out. Okay. These two. So Pseudomonas doesn't penetrate. So how will it cause keratitis?
I'm not very sure, ma'am.
Okay, so since your corneal epithelium is constantly under trauma, like it can rub, no, your contact lens can move
Yes.
either while
Yes.
putting or while removing, or even when your lid blinks, no, even when your eye blinks, it can move. So it can cause minor trivial trauma to the epithelium. It might not be significant, it will heal probably. But in case if the contact lens only harbors these infections, no, like Pseudomonas or Acanthamoeba, then you're more prone for that is a mode of entry.
Okay, ma'am.
Okay, and how an Acanthamoeba it causes? Simply contact lens wear will not cause Acanthamoeba keratitis. There should be along with that history of
Homemade solution used.
solution. Okay, what are the specific history? Where do you find Acanthamoeba? Rather.
Pond.
Yeah, so what exactly? Nobody uses pond water, no? But
Yes.
so somebody's
Swim.
given it out. Yeah, swimming. There is usually history of freshwater swimming. So in these patients who wear contact lens, not with normal eyes, okay, like not with normal patients. So in them, Acanthamoeba keratitis is more common.
Okay.
Okay. And then you say no previous episode of watering or discharge. Why previous episode? What against?
Ma'am, like any lid infections or any like dacrocystitis that can predispose to corneal ulcer, ma'am. That's why I asked a history
What
of any
corneal ulcer? Very good, but what corneal ulcer?
bacterial. Hello. Hello.
Yeah,
Bacterial, ma'am.
Yeah, which organism? Bacterial is too big.
Hello, ma'am. Ma'am, I cannot hear you. Hello.
Yeah, I'm asking which organism.
Yeah, ma'am, a pneumococcal can cause dacrocystitis.
Okay, and what about canaliculitis?
Ma'am, actinomyces.
Yeah, so in case of any of your dacryocystitis, there are two components. Either the canaliculi can be infected or your sac can be infected. If your sac is infected, it is more common your streptococcus. And if it is your canaliculitis, then it is actinomyces.
Yes.
Okay. Then coming to your history next. Yeah. Chronic topical medication. What topical medication? Raksha?
Ma'am, no application of any chronic topical.
Yeah, what topical?
Ma'am, yes, ma'am, your voice is breaking. I'm sorry, I couldn't hear you.
Yeah, am I audible now?
Hello? Yeah, ma'am, any chronic usage of corticosteroids.
Corticosteroids, you're saying. Okay. How will it cause?
Yes, ma'am, you're audible now, ma'am. Any prolonged antibiotic usage or corticosteroid usage.
How?
Hello?
Raksha?
Hello?
You're audible. Am I audible to you?
Ma'am, but your voice was breaking in between. Now I can hear you. I was saying that any topical medications like corticosteroids or any prolonged usage of any
Agreed.
antibiotic.
But how?
Okay.
How will it cause? Anybody in the chats? Natural defense mechanism. Okay, Vaishnavi, that is correct. But how will you justify it, huh? Beta blockers decreases sensation. Okay, very good. Beta blockers she didn't mention, but yes, it is known to cause what do you say, decreased sensations in the cornea. Agreed. That is more common. Yeah, okay.
Primolar usage, yeah.
How about your antibiotics? Prolonged antibiotics, you said.
Ma'am, again, the normal defense will be disturbed.
See, normal defense is only in case of corticosteroids, no?
Yes, ma'am.
Because they suppress your immune, as in immune suppression. So your immunity in the tear film will be suppressed. They want that. Agreed. Along with that, how topical symbiotic effect? What symbiotic effect? Can you explain? See, most of these topical antibiotics, no, they are epitheliotoxic.
Okay.
So most of them actually are toxic to the epithelium. So there is delayed epithelial healing in case if there is any defect, no, because of any trauma or anything. It is not going to heal in a similar way as it would in a person who's not using for a very long time. I'm saying it in case of a prolonged usage, okay, not for like 14 days or 1 month or something. Prolonged usage. So in them, it is epitheliotoxic. That's how your ulcers are gonna, it is going to lead to ulcers.
Okay.
Okay. And then you said HIV transplant malignancy. Until and unless asked, do not mention about your malignancy.
Okay,
You
ma'am.
can just say immunosuppression.
Okay.
Transplant and malignancy is not required actually. You can just combine it under the heading of immunosuppression.
Okay, ma'am.
You say diabetes, that also comes under your immunosuppression. How hypertension will affect corneal ulcer?
Ma'am, I just added hypertension with that.
So that you don't have to add it here. You can add it in your past history. That is for your systemic evaluation.
Yes. Okay.
Okay, that doesn't stand any significance in your ulcer. Since you have already come to the conclusion of an ulcer, you don't have to. You say joint pain, back pain, connective tissue disorder. Very good. How and what? What is the relevance?
They can present with connective tissue disorders is one of the predisposing factors in corneal ulcers, ma'am.
How?
They can cause uveitis, ma'am, actually.
You are actually deviating. You are very, you have mentioned a very good point, but the reasoning is not satisfactory. Anybody can give the reasoning. I'm looking into the chat box also simultaneously. Scleritis, no. Dystrophy, no. In relation to corneal ulcer, how? Any specific ulcer? Peripheral ulcerative keratitis. This is the term I was looking for. Okay. See, in rheumatoid arthritis, not exactly rheumatoid only. Rheumatoid is also associated, but any connective tissue disorder like vaginas, anything can actually cause peripheral ulcerative keratitis. So you're ruling out your peripheral ulcerative keratitis with by ruling out these things.
Okay, ma'am.
Back pain, why?
Ma'am, any joint involvement I asked as such.
You've written back pain.
Yeah.
What is it for?
I should have mentioned it.
Sorry?
Ma'am, I should have just mentioned it as joint pain and connective tissue disease.
But you mentioned back pain, no? What is it for? TB. Okay. Your tuberculosis.
Okay.
Ankylosing spondylitis also, but ankylosing spondylitis is not very commonly associated with your peripheral ulcerative keratitis.
Okay.
That is more common with your uveitis.
Yes, ma'am.
Okay.
Okay.
Tuberculosis is also, so you should have actually mentioned about cough, any chronic history of cough, all that.
Okay.
Then you say no history of similar disease in the past. What is that you're ruling out?
Ma'am, any recurrent cause of it, any traumatic, like any papillae, if it is present for a longer history, they would have previous similar episodes of ulceration before this.
So now you're repeatedly stressing on papillae. So I would say no to save the time. See, papillae and all will be associated in kids, and that in VKC, that is shield ulcer. Now you're dealing with a farmer who is 65 years. Do you expect papillae here?
Okay.
No. Somebody is given out the answer in the chat box. Very good. It's viral. Viral is recurrent. Any ulcer that you know that is recurrent is viral. It keeps reactivating.
Yes.
So in them, it stands significance. Apart from that, your fungal and bacterial, if it is healed, I don't think there is a chance of reinfection, as in there's a chance of recurrence until unless there is reinfection. It has to be de novo again. It can't be the same fungus that is dormant and then again reactivating. No, it is only in your viral. So herpetic eye disease, that is known to recur.
Okay.
Your viral keratitis is the one that you are ruling out here.
Okay, ma'am.
Okay, next slide. Past history, you've written everything, TB or asthma. Okay, asthma is for your corticosteroid usage. Epilepsy, why?
Ma'am, any trauma during the episode of seizures?
Unlikely.
Okay.
I've never come across any of that case. It's very rare. What better way to explain it? If you have written it, you should justify it somehow, and somehow it should be satisfying.
Yes, ma'am.
What is it? If you don't mind, don't write it, okay?
Okay.
Epileptic drugs, okay, but more often if epilepsy has any what do you say, any neurological deficits associated with epilepsy and that's causing bells, something like that, then you can. Otherwise, I don't think that stands a chance here to be mentioned.
Okay.
No relevant family history. What family history?
Like for any connective tissue disorders, ma'am, which would run in family.
He only doesn't have. Now how family?
Ma'am, that is why I asked to like this.
No, there's nothing significant in family history. Okay.
Okay, ma'am.
Probably tuberculosis. That's how it is stages. Apart from that, I don't think something should. Then the diet. Okay, in coming to this personal history, you have mentioned everything except for the major thing I was expecting here.
Ma'am, history of his habits.
Yeah, habits are very, very important in this ulcer case. People are going to look into it. You keep treating. Yeah, what happens in alcoholism? And
smoking as well, ma'am.
Yeah, how will it affect?
Immunosuppression only.
Yeah, but how? Immunosuppression is very vague term. What causes, what alcohol does actually? Malnutrition.
Malnutrition, yes, ma'am.
So any ulcer requires protein. You have to ask the patient to take protein supplements or other, if not supplements, in his daily diet only, he should include proteins, high protein diet. Otherwise, the ulcer anywhere, be it your leg, foot ulcer or your corneal ulcer, is unlikely to heal with all the maximum medications that you give.
Okay.
Similarly, tuberculosis, smoking also.
As well can cause.
Yeah.
Yes.
Okay, next.
General physical examination.
Okay, done. I would like to skip this.
Okay.
With this also, you're just ruling out malnutrition. That's all.
Yes, ma'am.
And next, coming to your ocular. So here you say head posture is normal. What is normal head posture?
Ma'am, the visual axis is parallel to the plane, tilted to either of the sides.
Sorry, I couldn't hear you. Can you come again?
Yes, ma'am. Ma'am, when the visual axis is parallel to the plane and the head is not tilted to the either of the sides.
Central.
Central in position.
Okay. Then facial symmetry is normal. You can just say facial symmetry is maintained. It's symmetrical both the sides. How is it significant here?
Ma'am, any seventh nerve palsy can cause exposure keratitis and lead to ulcer.
Okay. Yeah, forehead is normal. Why would you like to say forehead?
Again, to rule out any trauma, ma'am.
Trauma, by trauma, what do you mean? The whole face is involved. Trauma will be only to the eye, no?
Eye, yes.
Yeah, so forehead, by.
Facial nerve palsy.
Yeah, and
Raksha,
yes, ma'am.
if you have a corneal ulcer, any
Yes,
corneal ulcer, which corneal ulcer would you be more bothered to look for forehead, skin, and other things?
The herpetic, I mean the viral.
Okay, and trauma?
Ma'am, in?
Trauma, what you want to say?
In pertaining to forehead, ma'am?
Yeah, pertaining to orbit, forehead. Yeah, you can tell.
I'm not sure, ma'am.
Okay. Yeah, somebody's answering Rakunai and all. Okay. But actually, forehead you won't have much. You can only see contusions and things. This, but yeah, Rakunai in the orbit. Yes, vesicles in HZV. Correct, Neha. Yeah, go ahead. Go ahead.
Oh. Ma'am, should I read out the right eye first and then left eye?
No, not needed. You have written eyeball position as orthophoric. You write it as orthotropic. Now, what is the difference between orthotropia and orthophoria? You can't write orthophoria here.
Okay, ma'am.
You have to write first orthotropic. So, what is the difference? Okay, orthotropia is what is your manifest squint. Orthophoria is your latent squint. So your manifesting is, you mean ortho, that means your both the eyeballs are in central position. Okay. If you do cover uncover test or yeah, phoria means hidden. So it is latent. Tropia is your manifest. So you have to mention about first orthotropia and then orthophoria, but not directly orthophoria. Okay.
Okay.
Okay, we'll discuss
Raksha, one more question, just a trivia, okay. Rakunai, just because I just got stuck there.
Okay.
Where will you see Rakunai in a pediatric patient? If you get a pediatric patient, there's no history of any trauma.
Okay.
And you're seeing a Rakunai, Rakunai in both eyes. No history of trauma. Neha, parents are good. They're not doing any battered baby.
No history of trauma and Rakunai in pediatrics, ma'am.
Pediatric patient, yeah. Both eyes, I'm telling you, both eyes are involved.
Any hemophilias?
Homework. Anyone else? Yeah, Vaishnavi. We have a pediatrician here with us, Dr. Ashray. Please. Anyone? Okay, that's still a question. It's open. Anyone can answer it. You continue. In trauma, exactly where should be the trauma to cause raccoon? Like, did you get the question?
No, ma'am.
Like,
Yeah.
if you have a head trauma, yeah, very good. Somebody understood me. Manasa, correct. Anterior cranial fossa damage, and then you'll have a raccoon, correct.
Keeping of the blood.
Yeah, you will also see a subconjunctival hemorrhage, and the
Hemorrhage.
posterior border might not be very visible. So that's a cause of concern for you. Anytime you will have a subconjunctival hemorrhage, you have to look for the posterior border. Okay. Yeah, continue.
Extraocular movements were full and adequate in both the eyes.
Okay.
The lids, ma'am. Position of the lid was normal, but the lid margins looked edematous.
Only the margins?
Yes, ma'am.
Okay.
And eyelashes were normal. Skin was normal. Palpebral width was 25 millimeters, which was almost similar to that of the right eye, which is 26. Height was reduced due to edema. It was around 7 millimeters.
What do you call that?
Then the lacrimal. Ma'am?
What do you call? Like you said, the palpebral height is reduced to 7, no?
How?
What do you call that? Like, if it is reduced to 7, then what is it called? Like, if it is reduced, yeah, ptosis. So what type of ptosis?
Raksha, you have a lid edema and you have ptosis. What kind of ptosis is it? Yes, Akshay, correct. Yeah.
Mechanical ptosis, no, due to edema.
Okay.
Okay. And you say your lacrimal apparatus is normal.
Yes.
Okay, fine.
Why is sac syringing important here, Raksha?
Ma'am, dacrocystitis could be a precipitating cause for corneal ulcer.
Okay. That's all?
Canaliculitis. Hello? Yes, ma'am?
Go on, correct.
Any sac involvement can precipitate corneal ulcers, ma'am. So, sac syringing was done. And congestion was present, ma'am.
So in case if there is dacryocystitis, what would be your mode of treatment, like line of management?
Ma'am, topical antibiotics.
Think again.
Dacryocystitis.
What is the management for dacryocystitis?
Systemic antibiotics and topical.
That would be your line of management. No, dacryocystitis, if it is chronic, then you will have to do DCR. In case of your acute, then you reduce the inflammation. Then again, you have to do DCR. Otherwise, your corneal ulcer will never heal. With just antibiotics, plain antibiotics, your sac infection will never resolve.
Okay. DCR.
Yeah, so first you have to do DCR. If it is a chronic dacryocystitis, immediately do DCR. Otherwise, your ulcer will not heal. Ulcer will keep on progressing. It will become non-healing.
Ma'am, I'm not able to hear you, ma'am.
Raksha, you can hear?
Yes.
Vaishnavi, what is DCL? You've written DCL or DCR. What is DCL?
Okay. Ma'am, your voice is breaking. I'm not able to follow you, ma'am.
No, I was asking Vaishnavi, who's written DCL, not DCR. No. Okay, it's DCR. Yeah. If you have to
Hello?
name another surgery, it should be DCP,
Mm.
which people don't do these days much. Yeah. Raksha, can you hear?
Yes, ma'am. I can hear you now.
Yeah. Go ahead. Yeah, conjunctiva, please.
Conjunctiva, there was congestion more over the medial fornix. It was present throughout, ma'am. Upper and lower palpebral conjunctiva was also congested. There was circumciliary congestion as well.
Only congestion, no papillae, no follicles, nothing.
Nothing.
Okay. What does that say?
It is an acute condition.
Okay.
Mm.
I mean, I am just asking you, what else do you have to rule out if there is a cornea case? The reason I asked you for
follicle.
papillae, why?
Closure of eyelids will cause minor trauma, repeated minor traumas on the cornea, ma'am.
No, we are talking about conjunctiva here.
Okay.
And I asked you if there were any follicles or papillae on the conjunctiva, in the conjunctiva. I mean, you are telling palpebral conjunctiva, it might, okay. But what exactly do you want to look for? Someone, yes. Trachoma. Trachoma is a big thing. I am asking a very simple thing. Conjunctivitis also, no?
Oh, yes.
Yeah. Keratoconjunctivitis. So when there's a corneal involvement, please look for other infections. So since you saw for the dacrocystitis, you better see for conjunctivitis also. Okay. You don't have to do anything special. If you're giving antibiotics for the cornea, that will also take care of the conjunctiva. I'm just telling you have to look for it. Okay.
Okay, ma'am.
What else will you look for if you're reverting the lid?
Yeah.
Somebody said allergy also. Agreed. What exactly are you going to look for in allergy?
Papillae, ma'am.
Not every papillae will cause. What is that specific that will cause? That might. BKC will cause papillae, but what papillae?
Yes.
See, there are types of papillae, na?
Yes, ma'am.
Very simple it is. If it is huge, then it will cause. If it is normal, yeah. So giant papillae.
Giant papillae.
Okay.
Okay. So any of that, if it is there, then you should take care of that as well. And also any foreign body lodge there. That might be causing a field defect and non-healing ulcer.
Yeah, unless you remove the precipitating cause, whatever you treat, it's not going to work. Okay.
Yes, ma'am.
Yeah.
Ma'am, cornea size vertically measured about 11.3 millimeters and horizontally was 10.9 millimeters. It was normal but irregular surface. There was diffuse haziness of the entire cornea. Transparency was lost. And there was corneal thinning with iris being plastered to the cornea. Epithelial defect was 5 into 5 millimeter size. Infiltrate was 6 into 6. And Desmond membrane folds with corneal edema was present. And there's vascularization of cornea.
What vascularization?
Ma'am?
What type of vascularization?
Ascending, ma'am.
First you tell superficial or deep?
Superficial.
See, for this vascularization to develop, you're giving history of just 1 week. Unlikely, I will not see vascularization so soon. Even if it is, then it is, yeah, it can be anything. But whatever you've seen it, you have to tell. And
superficial vascularization.
Okay. But 1 week history, unlikely. I would not expect it there. Okay. Yeah, so infiltrate, you're saying 6 mm into 6 mm. It depends on the institute also, how they expect you to describe the infiltrate. So if you're saying first you have to mention about the epithelial defect, not the infiltrate. So epithelial defect is 5 × 5 mm, which is central in position with surrounding 1 mm infiltrate. Okay. The infiltrate is always more at the margin. You're saying the cornea is thinned and iris is plastered to the cornea. Okay, so with surrounding 1 mm is probably a better way to describe in infiltrate. That's how we used to describe. I don't know how they have taught you in your college.
Raksha,
Yes.
all places, it's better to go from epithelium. Okay, so
Okay.
first start with epithelial defect only. That's the way it is. Okay.
Okay, ma'am.
Like usually you tell about the whatever size, shape, and everything. And
Okay.
thinning, when you're telling corneal thinning, like here you're telling it is plastered. Just say told corneal thinning with iris plastered to cornea. You also have to tell how much percentage it's thinned out. So when you're making that slit now, corneal slit, you can actually see if it is 30%, approximately, whatever. This much is thinned out. In keratoconus cases and all, it will be very important for you to tell that.
Yes.
How much of the cornea is thinned out and in which region. So
Okay,
you're
ma'am.
just telling corneal thinning. I don't know which clock are to which clock are.
Okay.
So here, nowhere I've been, where you have mentioned where is the epithelial defect. So I'm not able to picturize it in this description. Understood?
Okay, ma'am.
See, you have to tell me how much is the defect or how much is the infiltrate from which cloaca to which cloaca, and how much away from the limbus or the pupillary margin or wherever it is. Okay. So you get a picture even without seeing your diagram, only with your description. The examiner should get to know where the ulcer is. Did you understand?
Okay.
Did you get it? Yeah. So first thing is
Yes, ma'am.
always start with epithelium. When you're describing the ulcer, always start with the epithelium, then go to stroma, then go to endothelium.
Okay, ma'am.
And if you're seeing decimal folds and all, then in the order of the layers of the cornea.
Okay, ma'am.
Everybody, most of the that's a very systematic way of doing it. Correct, na, ma'am?
Yeah.
So
Ma'am,
now you know that now I told you like I want a description like this. So think about your case and describe it like this.
Okay. Ma'am, the cornea looked normal but irregular. There was epithelial defect measuring of 5 into 5 millimeter size and infiltrate of 6 into 6 millimeter size. Uh, there is a corneal thinning with iris plastered to cornea, DMFs with corneal edema, and diffuse haziness was present throughout the cornea. Corneal transparency was absent.
You're just telling the same thing again, Raksha. You tell me which clock are to which clock are.
No.
I still can't picturize.
Yeah, okay. Yes. Corneal
3
thinning
to
was
6.
present.
Like that. Yeah, go ahead.
5 to 7 clock hour, ma'am.
Okay. Near the limbus, near the
Ma'am, can you hear me?
margin. Yeah, I can hear you.
Hello?
We can hear you, Raksha.
Towards the limbus, ma'am. 5 to 7 clock hours towards the limbus.
Towards Salah. Like you have to tell me how much away from the, is it limbus involving or 1 mm away from the limbus, 2 mm away from the limbus, that is towards the center of the cornea, like that. Like how you have drawn. I'm sure you would have drawn a corneal diagram. But not every examiner will look at the diagram. They want you to describe the diagram to them.
Okay, ma'am.
So you would have drawn. So I want you to explain that drawing.
Okay. Ma'am, corneal thinning was present 2 mm away from the limbus.
Okay.
It was almost from 2 to 5 clock hours, ma'am.
2 to 5 clock hours. Which side? Which limbus? Nasal or temporal limbus?
Temporal limbus.
Superior or inferior limbus? See, again, it's a very vague. I am not still able to picturize.
Okay.
Got it? So
Yes,
you have to be very, very clear when you're telling, okay, that I am seeing this corneal thinning, which is about approximately 30% corneal thinning. I am seeing from 2 o'clock to 5 o'clock, 1 centimeter, 1 millimeter away from the nasal limbus.
Okay.
So now, after I told this, everybody is able to picturize, okay, the corneal thinning is there near the nasal limbus, 1 mm towards inside of the nasal limbus, at this to this clock hour or whatever. Nasal limbus means it's not 2 to 5, it has to be 4 to 7 or something, like 7 to 10 or something like that. Okay. So
Okay, ma'am.
you have to tell the clock hours according to whichever limbus you're telling. So be very properly describing it. Now your
Okay.
epithelial, just let us come to your epithelial defect. That was where exactly?
Epithelial defect was like 1 millimeter away from the pupil at
Hmm.
4 to 7 clock hour, 4 to 6 clock hour, ma'am. That position
4
in
to
the
6. So
temporal limbus.
okay. 10 other temporal. Okay, fine. And that was 5 into 5. Now, how did
5
you
into
see
5.
for the epithelial defect? Did you just see the slit lamp or did you use some dye or something?
No, ma'am. I didn't use the dye with the. No, I used the dye, ma'am. And after that, on under slit lamp, it was measured.
Under slit lamp, it was measured. So you can just say what dye did you use?
Fluorescent staining dye.
So fluorescein staining present also you can write when you're writing. Okay. Epithelial
Okay.
defect present. FS positive is fluorescein staining positive.
Hmm.
Okay. You can just mention it. Not that
Mention.
everybody uses it or senior consultants normally don't. But then when you're starting, it's always better to use a dye, measure it properly. Now, how do you
Okay.
measure? Which axis do you measure? You have a very irregular epithelial defect supposedly. How
Ma'am,
will you measure it?
the longest axis I measured it.
First longest axis you will measure. The second number that you write. So you've written 5 into 5 now. So
Yeah,
first 5 is your
perpendicular
longest
to that.
axis. Exactly. You have to make 90 degrees to that perpendicular, whatever is there. That is this thing. And how did you measure it? By the slit lamp?
Um, Ma'am, by narrowing the slit beam.
Yeah, you have to for all the benefits of the UG students here in the slit lamp you have you can make your slit at different sizes. So the slit lamp has 10, 5 mm, 3 mm, 2 mm, 1 mm, all these slits. Okay, so just by turning a knob, you can make a slit of this much mm. It is written in the, like once you turn the knob, that number comes up. So you can actually adjust your slit to the size of the ulcer and just look at how much is your slit size. Okay, and that gives you an approximation as to how much is the size of the epithelial defect or where is the infiltrate. Okay, so you can, if you go back, since all the colleges are reopening, you can as well visit your ophthalmology OPD, just see the slit lamp once, ask somebody to show you where the slit can be adjusted. Okay, so that's how you can measure the ulcer.
Yes.
Yeah.
And
Ma'am, anything else? Yeah, sorry, something you were telling. Yeah.
No, ma'am. No.
DM folds, how do you see? Yeah. How do you see? Like whether they were vertical, horizontal, how?
Ma'am, it was horizontally present, ma'am.
Horizontal. Where all do you see DM folds? Where do you commonly see DM folds?
Why is it horizontal?
Yeah, that is one more question.
Ma'am, I lost you, ma'am. I cannot hear you.
Can you hear me now?
Hello?
Raksha, I'm asking why is it horizontal DM folds?
Ma'am, I'm so sorry. I lost you. I couldn't hear you, ma'am.
Why are the DM folds horizontal in your case?
Ma'am, I meant vertical, not horizontal, ma'am.
Why are they vertical? What are these DM folds? What do they represent?
The Descemet membrane is the fluid is seeped in there.
What fluid?
Okay.
Edema, ma'am.
Yeah, what edema? Where is that edema coming from?
See, if you have to see a
Actually,
fold, now,
yes, ma'am.
how will the fold, any fold, when does that fold happen?
Due to collection of there's a lot of fluid like edematous, and
Above it or below it?
below it, ma'am.
You're not getting the question. Why are DM folds present in your case? There are two reasons. If you can justify, you can. Otherwise, I'll give it out.
I'm not very sure, ma'am.
Very good. So in your case, it could be your inflammatory edema. Okay. Either there is surrounding inflammation, as in the cornea is the ulcer is inflamed. No, it is nothing but your inflammation. No, infiltrates are all leukocytes. So along with that, the reactionary edema is there in the surrounding because there are a lot of reactions in your AC. That you have hypopion and all. So hypopion is great for anterior chamber reaction. So that will cause endothelitis, and then your endothelium is decompensated, and then you can have edema. But you also said your iris is plastered to the cornea.
Yes,
So that means there has been a what does that mean? Why is iris plastered to the cornea? Normally it doesn't, no?
Yes, ma'am.
So it is perforated. Good.
Yes.
There is perforation. There could have been perforation which the iris is sealing. So when in this case, you will see radial folds. The folds are because of the hypotony. The radial folds will be seen from the side of perforation. Like if your perforation is in the center where the iris is plastered, surrounding from that, the folds will emerge radially. Got it?
Okay.
Yeah.
So these two reasons.
Yeah, correct. Good, ma'am. Yes, ma'am.
Okay.
One more trivia question here. Okay. If there is a hypotony, which other ocular structure might show folds? Just that if there is a
Okay, ma'am.
if eye is not pertaining to this case, I told you it's a trivia question. If there is ocular hypotony, if there is a hypotonous eye, that means it is not having the proper rigidity that a normal eye has. So you will obviously start seeing folds. Okay. Which other ocular structure will show folds? This is for everyone else. Just a trivia again. Second trivia question to answer. Retinal detachment. No, detachment.
Beyond retina.
Beyond retina, yeah. Correct. You are somewhere near. Very good. Yeah. Okay,
Choroid,
Akshay
yeah,
has told. Correct. Yeah, claps to you, Akshay. It's choroid. Yeah, very good. There's something called as hypotonous maculopathy also. Okay. And yeah, choroid, you see folds.
Choroidal. Okay.
Choroidal folds you can see. All right. Yeah, continue. The other question still open. Okay, people. That pediatric question that I asked. Yeah. Go ahead. Go ahead.
Ma'am,
So show your diagram
sensation
now.
This.
How did you check corneal sensation?
Ma'am, patient was made to sit, look straight, and I was standing behind the patient using a thin cotton film. It was checked in all the quadrants.
Don't use the word film. Okay. Cotton film. What is cotton film?
A thin cotton swab.
Swab?
No.
These are English terms. There's nothing big things in here. But all this might affect your case presentation. Okay. So it's not a swab. It's not a film. What is it? Wisp. WISP. Okay. Not wisp. Akshay. No H there. Wisp. Cotton wisp. Okay. So you'll make a cotton wisp. And then, yeah, continue.
And then sensation was checked in all quadrants, standing behind the patient.
You'll stand behind. So then how will you see the reaction? I mean, for both eyes, you'll stand on the head end side. Behind, as in behind the chair of the slit lamp.
Behind the chair.
Or towards the side, or where will you stand? See, all this, they will not ask you. They might see how you're doing it. That's all.
Towards that particular side of the eye. If I'm checking on the right, I'll be towards like behind.
Correct. Okay, and you'll actually look for a blinking response, correct?
Yes, ma'am.
Okay. Next.
And it was intact in all the quadrants, ma'am.
Okay, suppose the patient had complete ptosis in one eye.
Okay.
How will you check the corneal sensations in that eye?
I'm not sure, ma'am.
See, did you get the question? Did everybody get
Yeah.
the question?
Yes, ma'am. If it's
See, you have a
total.
patient who has third nerve palsy probably. So he has complete ptosis in one of the eyes. Suppose right eye complete ptosis. Okay. So you can't lift the lid. If you lift the lid, then how will you see the blinking response?
A blinking response.
Correct, na? So how will you check for whether there is
Yes,
a
ma'am.
corneal sensation there also or not? Blinks other eye too. Yeah, very good. Okay. Very good. Neha, that's very right. Yeah. So what exactly are you doing there? Blinking response is bilateral, okay? You can't, unless you're trying to wink at a person, if you're actually blinking the eye, your both eyes will close, both eyes will open. All right. So if you are touching the wisp to the right eye, and if you are seeing a response from the left eye also, that means there is some blinking response. That is, the corneal sensations are intact.
Corneal
Okay. So then the pathway and all you have to read now. We can't really discuss that. Okay. What is the corneal sensation? What is the efferent? What is the efferent? All that. Please read up. Okay. That's all theory. Yeah. Go ahead.
Yeah.
Wait.
Ma'am,
That corneal diagram, ma'am. Anything in that? See, there's something called as color coding. Okay, like you have to know the color codes for no. For this is for the PGs. All the PGs, if they are watching it or will they whenever they'll watch it, there is a color coding system for corneal diagrams. There is a color coding system for retina diagrams. Both these things you better make one chart and stick it in your room. Okay, every day just keep looking at it. Okay, you can't really by heart which color what, and the best way to go about it is carry color pencils. Always have these are the only PGs who will carry color pencils with them. Okay, Ophthalm PGs. Please keep it in your pocket, and whenever you get a case, try to draw it in the color pencils. So you might draw it in your pen also. Nobody will say nothing. If it's a very busy OPD, nobody is going to literally come and check. If your institute is like that, then great. But then try to use those same colors when you're drawing. That will help you in your exams as well. So then you don't have to sit and think, okay, infiltrate is in yellow, epithelial defect was green, edema was blue. All these things you need not really think. It will automatically come. Okay. And whenever you're asked a corneal ulcer question in your exam, draw a picture. Any picture, like if it's a fungal corneal ulcer, draw a picture. Both and what you've drawn is just the AP, like just the straight view. That is not enough for a corneal ulcer case.
Okay.
You have to draw one straight picture and then you have to draw a section. Section as in you have to put a dotted line. From in this picture, if I have to explain it, from top to down, you have to mark a line like a slit, okay, like a curved line. And in that slit, where what you are seeing, that again you have to draw. You have to make something called as a parallelepiped. Okay, that is your slit. Okay, so then you can show in the layers of the cornea, that is epithelium, stroma, endothelium, and the AC. You have to draw the hypopion. So you have a slit section also. So depending on how much is your ulcer, that many slits you can also draw. This is for the benefit of really nicely scoring in your exams. Okay. So draw one straight picture and also draw a picture which is giving you a parallelepiped and sections at each different level of the cornea. So then that is going to give a clear picture to the examiner that you know what you're doing. Okay. At least that you're going to anyway. See, that's the best thing. When you can't answer, don't mess it up. Just say I don't know. But whatever you know is in your case sheet, let it be very neat. Okay. So draw this. You have only given us one picture, so that we really can't comment much. You have to keep other pictures also, slit pictures and parallelepiped pictures. Okay.
Okay, ma'am.
Ma'am, anything else in the diagram?
Yeah, the color coding part and the cross section.
Okay, ma'am.
I don't think there's much.
If the iris is plastered to cornea, all that, no, you have to really write all that properly. There is
Okay.
color codings, okay?
Yeah, I think the picture will be better if you do it color coding. It will be
Okay.
self-explanatory.
Okay, ma'am.
Okay.
Um,
Yeah, now you say AC couldn't be made out.
Chamber.
Raksha, can you hear?
Yeah. There was like because the ulcer was present, I cannot clearly tell about the anterior chamber, but
Hi, you said the
No,
iris
no,
is
no.
plastered.
See, then where is the anterior chamber?
ma'am, I'm so sorry, I'm unable to hear you, ma'am.
Okay. Is it okay now? Raksha?
Raksha.
Sorry, ma'am.
Can you hear now?
Yeah, now I can hear you, ma'am.
Okay, very good. So the thing is, come to AC.
Yes, ma'am, I can hear you now.
Yeah, very good. Come to the AC.
Ma'am, I can hear
Anterior
you.
chamber. Yeah. Okay.
Yeah.
The thing is, you've written couldn't be made out due to haziness, na? Where is the AC to make out? Hello?
AC.
Hello, Raksha? Okay, for the benefit of all the other UG students here, what exactly will you look for in the AC in a case of corneal ulcer? Answer fast. 1, 2, 3, 4. Yes, hypopion. Then? Okay, hypopion done. Accepted. Very good. Claps to Neha, claps to Akshay. Then, next. Only hypopion. You don't want to see anything else in the AC. If at all AC was present, let's not ask about this case. Yeah, aqueous cells flare, hyphema. Okay. Okay. You have to tell me the reason. Like that, even I can go on telling. Why each of it? Cells and flare for uveitis. What kind of uveitis with corneal ulcer? What uveitis can present with an ulcer also? That's the question. No, not obviously anterior uveitis. Na Neha, we're not talking about vitritis, choroid and all that. I'm asking you etiology, not the location. Because serpens. Is that pneumococcal serpens? I don't know, I really. Okay. No, wait. I'm asking a very common one. A very common cause of a corneal ulcer. Very good. Herpes, okay. Herpes uveitis is also very common. Herpes iridocyclitis can be there. Herpes ulcer also can be there. And what exactly is the clinching diagnosis if you have to say it's a herpes ulcer? What kind of an ulcer do you see? Painless. Painless, okay, that's history. But why is there no pain? If you're saying painless. Yeah, there's loss of corneal sensation. So when you're checking for the corneal sensations, it will be decreased. Yes. Okay, correct. Very good. Now I'll ask you one question, which is the ulcer which has extreme pain. Like you might not actually find that much findings, but the patient complains of extreme pain, like out of proportion. Very good. Acanthamoeba, okay. And acanthamoeba presents as what? What kind of an ulcer?
Hello, ma'am.
Yeah, Raksha, we have you back.
Sorry, I lost you.
No problem.
Yeah. Ma'am, yeah. What was the question, ma'am?
AC. We were talking about AC.
Yes,
Okay, so
ma'am.
you've written as couldn't appreciate the anterior chamber due to haziness.
Yes,
But you've
ma'am.
also written that iris is plastered to the cornea. So where is
Yes.
the question of anterior chamber here?
Yes.
No, no, you tell me. Because how much of the iris was plastered to the cornea? Which quadrant? Which was the entire iris plastered? What are you trying to tell? Iris was plastered to cornea. It can be at a specific
No,
area,
ma'am.
not like it has to be
Not
complete.
the entire iris.
Not the entire iris. So where was it?
It was only inferiorly from
Hmm.
4 to 6 o'clock her position, ma'am.
4 to 6, it was plastered. The other
Yes.
side? The other side was not plastered, is it?
Ma'am, that's what I meant by I couldn't make out like uh,
No,
entirely because of laziness and edema.
no. I'm not asking what was there in the AC. I'm not saying
Okay.
whether the cells were there present or not. I'm just asking you where the iris was plastered. Only 4 to 6 o'clock.
Yes, ma'am.
Okay. So the other places, the iris was not plastered to the cornea.
No, ma'am.
So there was AC. That is what we are trying to make out. Okay.
Because hypopion is, yeah.
Okay, there was hypopion 4 to 6, and then you saw the hypopion also. Hypopion was which side?
Inferiorly, ma'am.
Inferiorly, you have iris plastered na 4 to 6.
At like towards the nasally, ma'am.
Nasally, you had some hypopion. Okay, was it mobile? Was
Um,
it moving? Was it
mobile.
stained? Any color?
Yes,
Nothing.
ma'am. It was mobile.
Okay, okay, very good. Yeah, then you couldn't appreciate the details, as in you can't say the depth and you can't say the cells and flare. That is
Yes,
what you mean, right?
yes, ma'am.
Okay. Anything, ma'am? Hello, Akshata, ma'am.
Yeah, I can hear you.
Yeah. Anything else, ma'am, in anterior chamber?
I think that's all. What else can you see? If it is associated with hyphema,
Yeah.
is there any specific ulcer?
Ma'am,
Very good. It's already there in the chat box.
ma'am, pneumofocal can present with hemorrhagic.
Herpetic.
Herpetics.
You if a consultant has seen one herpetic ulcer and come, no, your all questions will be directed like that, like how we are asking today. Uveitic, herpetic uveitis, herpetic hyphema, herpetic this. Okay. So take clues from the examiner also.
Okay.
Yeah. Then come on, go ahead.
So you didn't mention about the hypopion, whether it was fixed or it was mobile.
Ma'am, it was mobile, ma'am.
So how did you check for it?
I asked the patient to lie on the left side for 5 minutes. After initial examination, the patient was made to lie on the left side, and then when the patient was re-examined, the hypopion was not in the place where I initially saw it.
Where had it moved?
It had moved like.
No, you said left side.
Left eye, left side.
Left eye, left side, and mind you, you told 4 to 6 o'clock iris is plastered.
Yes, ma'am.
You just think, you sit, you think it, I mean, God forbid, don't have to do like that, but just think it in your own side. If you lie down on the left side, okay, and the involvement is in the left eye,
Yes,
and you said the 4 to 6 o'clock there was iris plastering, where would have the hypopion moved?
Yeah.
Just slightly it would have changed, that's all.
Yeah.
Okay, it would have been like yeah. We wouldn't be able to really
appreciate the moment. Yes.
pick it up as like, oh, so much of a difference. Okay, so you can actually make, what else can you do?
Make the patient lie on the right side, ma'am.
Okay,
Then the hypopyon would have moved, appreciated better. The movement would be better.
even I have not done this. I'm just thinking now how it will be.
Because it was unable to.
Correct,
Like,
Alva, ma'am. If she goes for left side, will it be appreciated better?
Yeah, it can be, but it depends how your iris and your anterior chamber. See, once it is perforated, I don't expect hypopyon. If it is iris plastered, hypopyon is not going to be there, because even that would have come out, oozed out.
Yeah.
Okay, so if hypopyon is formed, then it is a fresh hypopyon. It could be mostly a reactionary hypopyon. Unlikely it is fungal. If it was fungal, then it would not form again. If it was, then it would not again. Since it is bacterial, it is reactionary, it can. I'm not saying no. Then again, the hypopyon wouldn't be central. If the iris is plastered from 4 to 6, no, it wouldn't be central in position. The position only would be some nasal.
Okay.
And if the iris is plastered centrally, I don't think it should affect the movement of the hypopyon peripherally. Okay, if your iris is plastered, if you have peripheral anterior synechiae and all, okay, agreed. But if iris is plastered centrally, there would be some space
For the
around the periphery for the hypopyon to move.
Yes, you have to mention this. Yeah, you did not mention about any synechiae.
Yes,
so this you have to mention. This is important. Okay, peripheral
Okay.
anterior synechiae. If it is there, you have to tell, because otherwise we can't really picture where it is or how much is it plastered, whether there is any peripheral space left or not. All this you
I
can't
think
picture.
your diagram would have explained everything.
If you had drawn a cross-section diagram,
Okay, ma'am.
so then we would have known whether the iris was only from 3 mm plastered from the pupillary area, means the peripheral area was okay. So that then the hypopyon, whatever was formed reactionary, could move little bit in the periphery. But if there was peripheral synechiae, then there's no scope of that much of movement and all. So all this will see, that is because now all this doubt arises because we couldn't picture the ulcer now.
Yes, ma'am.
Okay. So if you when you are presenting now, especially now, when most of the exams and most of the presentations are happening all online or due to and you won't really get a patient to show it to your examiner. So the examiner will not be biased. Now sometimes when you actually show the patient and all, the examiner will be okay. He's also seen, so there might be a chance. Normally not. In PG exam, nobody will give you like that. But anyway, in this kind of cases, it is very difficult to explain to somebody.
Okay.
So your whole cornea case depends on the cornea examination and your diagram. And the effective way of you conveying to your examiner where exactly it is, how much it is, to what involvement, to how much depth involvement it is.
Okay.
That much if you tell, you are through. You definitely pass the exam. Okay. You don't have to be very high-fi in your investigation and all that. Just clinical examination, if you've done correctly, basically they only want to know whether when you become a specialist, a patient is safe in your hands or not. That's all.
Okay.
So you should not do something very majorly blunder type. Otherwise, everything is.
Again, pupil. I was not able to see the reaction or
you can't really. If iris is plastered, you can't regularly forget about that. You can't really do anything about it.
And any of the posterior structures, disc macula was unable to assess.
Okay, so what will you do in this case if you have an ulcer, corneal ulcer patient? You can't see the fundus. You can't see the what? What will you do? What investigation will you ask?
OCT, ma'am.
Yours is a government setup. Let us start there. The patient is not affordable for OCT. Do you know how much OCT costs?
250.
250.
No,
that's all OCT
has what significance in this? Rather, even if you and something else, OCT has very little significance in this. What are you actually going to pick up? What do you want to do else? What else do you want to do? Your setup has both OCT and everything else it has, but still your investigation of choice will not be AS OCT. Not even posterior segment OCT.
No, both OCT is ruled out. And the patient is affordable, very rich. He is ready to pay anything that you ask. Now you tell. Still you will not ask OCT. Why?
What else will you ask? If you know that, you will answer this. What do you want to look?
In a mature cataract, what would you ask?
If you can't see fundus,
yes, ma'am.
the other way to see it.
Correct. Don't freak out. You know this. You very well know this, Raksha.
B scan. Somebody's written it.
Yeah. Okay.
So posterior, it's an indirect way to see the vitreous, visualize the vitreous and your retina.
Okay.
So why is it important to know the status of vitreous in retina?
Ma'am, if there's a perforated corneal ulcer, it can involve vitreous.
Can involve vitreous. Oh, okay. As in
Like
guarded visual prognosis, somebody is telling. Okay. No, but lens is intact, na? Your corneal ulcer is perforated. Really, posterior segment surgeons will not really care much about it.
Yes, ma'am.
Okay. They'll not think, okay, why should vitreous come there?
Any complication of corneal ulcer that you want to rule out?
Somebody is telling me after treatment also many not get vision if there was any other issue. This is a very layman way of answering, Neha. You can do much better. Medical legal.
Not medical legal. I'm saying if you have a corneal ulcer and you want to do B scan, your first, you don't know it is an ulcer, it is perforated or not perforated. Yeah, extension of infection. So it can be associated with your outside external perforation or not. But what exactly is the complication of corneal ulcer? If you go read back, endophthalmitis can also be there, no?
See, basic, no? End of.
Yes.
What you will see in end of B scan?
I'm not sure.
Hyperechoic lesions in the vitreous cavity. Okay. With an active infection. Query suggestive of. That's how you will tell. You will not tell it is endophthalmitis. Okay. Every time you have to be. That's how radiologists report. So B scan is a radiological thing.
And
so
also, your normal vitreous will be anechoic. That means there will be no spikes in the retina, in the vitreous. Okay. That means the vitreous is clear. So sound waves don't have any reflections. Once there is something in the vitreous, that will reflect you as spikes. So your it can be hyperechoic. So what happens in this? You are only visualizing your ultrasound. Okay. You don't know if it is due to hemorrhage or if it is due to inflammation. You don't know. It can be your uveitis, it can be your endophthalmitis, or it can be vitreous hemorrhage also. All of them will just show spikes and hyperreflectivity in your B scan. So that's how you can't differentiate amongst these three. And that's where you write query. You don't know. He can be a diabetic and he will have vitreous hemorrhage. It need not be your end off. Okay, so this is just to rule out. In case if there is something, then you also see other signs in your B scan. If retina is thickened, RCT is thickened or not. All those will come.
Okay, choroidal thickening, all that, effusion, if that was any, all that you have to check. Okay, so you will have a patient coming to you. That's why I said you have to just tell what echoic lesions you are seeing in the vitreous cavity, with which quadrant you saw that, and clinically, like you have to correlate clinically what it is, since many of it looks the same. Okay, so only anatomically you can make out. You can't see physiological things. Okay, in B scan. It's a very anatomical localization. So for you to, it's a mandatory thing. Now, when you have a patient in whom you cannot see the fundus, it is very, very mandatory in today's practice to check the retina by a B scan. Okay. And you said digital tonometry. I'm not very happy with digital tonometry in a corneal ulcer case.
Ma'am,
Why am I not happy with the digital tonometry? You tell me first. Let's not consider this case, any case in general, any corneal ulcer case. I will not allow anybody to come and poke the eye and do that.
Painful.
First of all, I wouldn't let you touch the eye with your bare hands. You will have to wear a glove. And then, yeah, I wouldn't let anybody do that, fluctuation kind of thing also on the eye. So what is better?
A non-contact IOP checking.
Okay, that is one good thing. Yes, otherwise, that's still ear puff and all.
No, in NCT, Myers won't form. You can't do it in a corneal ulcer.
You can't do,
NCT.
yeah.
Okay.
You can't do that, correct. What else?
How else will you do it?
Tono pen, ma'am.
Yeah,
very good. Very good. Tono pen. Okay.
It is a contact procedure, but still you will do it, and you will always sterilize the cap.
Okay.
You can sterilize it.
You can get changeable this also for some tono pens.
Yeah, disposable.
Disposable ones. Yeah.
And you say yours is slightly harder than the right eye. You're totally contradicting your clinical picture. You told iris is plastered. You said it is perforated. Perforated eye will be hypotonic.
Hypotonic, no?
Yes, ma'am.
If it is harder, that means what?
I'm telling more in favor of like glaucoma.
Secondary glaucoma. Secondary glaucoma will develop only when the eye is, see, that stage has already passed out in this case. Probably the IOP was high, it couldn't, the corneal thinning was so high, so much that it couldn't sustain, and it's perforated and iris is plastered.
Yes.
If not, I don't see a reason why iris will come and plug into that cornea over there where it is thinned out. So that stage of your ulcer is over. So here I either expect it to be slightly lower or normal. More likely lower. Okay, and visual acuity, mention it in the beginning.
Yeah, I was about to say that too. Okay, any case, see, for your exam, in your practice also, the first thing that matters to you is the vision. See, whatever treatment you do now, patient is going to only realize that treatment by the basis of the vision he or she gets.
Okay.
He is not going to know that whether you are giving antifungal, antibiotic, whatever. For you, your treatment is correct. For patient, how will he assess you? He or she will know that you are a good doctor only when they get the vision.
Yes, ma'am. Okay.
Vision is the prime most thing. So very first thing you have to tell is the vision.
Okay, ma'am. Fine.
So that gives an idea to the examiner as to what the patient is actually complaining of. What is the problem? And how much it can be corrected to.
Okay.
Correct. So first, all the time, make it a habit. Just say the vision first.
Okay.
Even in your normal OPDs, when you are presenting to your consultants or something, just say first the vision.
Vision. Okay. Summary.
Summary, you don't write so big.
Okay.
It should be a gist, as in just summary is too much. Duration, causative factor, query trauma. There is no query in your summary.
Okay.
Okay, I'll tell you, Raksha. Now I'll give you one this thing. Okay, you are in Akshatha ma'am's OPD. Okay. And she's already seeing some 50 patients already. Okay. This is like the 61st patient. And you are seeing this patient. And ma'am has to do, and it's almost evening now. So you have to tell her in very short what this patient is having.
Okay.
So you can't tell this much story.
Okay.
No. Summarize it in 3 lines.
Okay. Ma'am, 65-year-old patient with complaints of pain, redness, and diminution since 1 week. On examination, had edematous lid and palpable height reduced to 7 mm. There's congestion all over the conjunctiva, and cornea had epithelial defect and iris plastered to the cornea with infiltrate being around 6 millimeters, and diffuse haziness was present.
Vision you didn't tell only.
Vision, yes. Vision was counting finger 1 meter on the left eye. with 6/12 on second eye. I mean right eye.
You don't have to tell right eye. You can just say, ma'am, right eye normal.
Right eye.
If nothing was there.
Hmm.
Right eye NAD, left eye
Okay.
OD normal, OS you are seeing this. Okay. And if you strongly feel, you don't have to tell one thing. You say perforated corneal ulcer, ma'am.
Okay.
Then if your consultant doesn't like it, then they will ask you, describe.
Okay.
Describe. Then you have to describe and then they will get the patient inside and show it to her. Okay.
Okay, ma'am.
Then you will be asked questions, told to draw diagram, all that. This is what normally happens. Correct, na ma'am?
Yeah, correct.
Hey, what is this goniometry, Manasa? What are you asking? I don't know anything called as goniometry.
Okay, and you have your treatment also. There are a lot of modifications in your treatment that I had doubts. Go to the next slide. Investigations. Okay, you have said it is gram-positive cocci.
Okay.
Okay, so this is your culture reports are awaited then. It's just gram staining that you've done.
Yes.
Culture you've not mentioned, so culture is awaited. I'm assuming it.
Yes, ma'am.
So next slide. When you have no fungal elements, there's no role of natamet early. First of all, no role of natamet if it is not a fungal ulcer.
No, ma'am. Okay, fine.
And therapeutic scraping.
Change based on.
It's perforated ulcer. You will not do scraping. It's already thinned out. If you scrape, it will again perforate. There's no role of therapeutic scraping in this case.
Okay.
And what is this fortified zone?
Zone. What is zone? First thing, what is the spelling of the zone?
Spelling XONE.
What is XONE? What is XONE?
Zones.
You can't write.
Okay.
When you're presenting the case, you can't write any brand name or this thing, generic name.
Okay, ma'am.
Tell what is zone.
Ceftriaxone, which is diluted in 10 ml of normal saline.
Will you give ceftriaxone?
Next question.
If your fortification is the treatment, then what will you fortify more than ceftriaxone?
Ma'am, cefazolin.
Yeah, cefazolin. Cefazolin has to be. And you have to mention the percentage.
Yeah, ma'am, 5 to 10% usually.
Okay. And no role of natamet. So what other antibiotic fortification will you do?
Hey, by the way, what is natamet? Natamet is antifungal or antibiotic?
Antifungal, ma'am.
Really?
That is the whole reason. You said KOH is negative. Why will you give natamet?
Yeah. Ma'am, like the treatment was changed after the staining report.
You have your treatment now. Whatever is changed, you have to tell that because you have the reports. KOH, you will get report immediately. You don't have to wait also.
Okay.
It's side by side only you can do, yeah. Okay, patient is still in the OPD, there on the side may only you can put one KH mount and get it done. Okay?
Yes. Ma'am, zone can be combined with.
I'm repeating it. Cefazolin. It is not.
Okay.
Cefazolin is done. Along with that, what else will you?
Tobramycin can be given.
Fortified tobramycin percentage?
1%.
No, go and look back. It's not 1. Along with that.
Ma'am, fluoroquinolones with tobramycin can be put. Gatiflox, moxiflox, and tobramycin.
Fortification is already done, so you don't have the role of fluoroquinolones here. Okay, your cefazolin will cover most of your gram-positive and it's a broad spectrum, but your amikacin and group will cover your gentamicin, your tobramycin will cover gram-negative. Now you are saying all these are early, agreed. After that, homide also early.
Ma'am, timolol is BD, ma'am.
No, homide?
Homide was BD.
TDS. Role of homide is TDS.
You don't put homide early, okay?
Yeah.
Okay, so whenever you are writing, you have to write, see, first thing, whenever you are writing the drug, you have to mention which eye you are giving the drug.
Okay.
And the generic name of the drug. Write it in
Okay.
capital letters.
Mm.
Also write what form of the drug you're giving, that is drop, ointment, fortified, whatever, what
Okay.
form you're giving it, how many times you are giving the drop, what is the percentage of the drop, that is weight by volume, okay, and the frequency and the duration.
Okay, ma'am.
So all this should be there when you're telling the treatment.
Okay.
This telling, okay, topical, this steroids, topical, this cycloplegic, this is very vague. Okay.
Okay.
So when you are telling, okay, my treatment is this drop with this much concentration, which is given at this much frequency for this much time. And I will review the patient after this much time. Okay. So that is how you're going to present your case. And for this now, you read Kansky. Kansky nalla chana kottidare, aita? So there is a table also in that where there is fortification also.
Okay.
Better books are there. You can read Namrata Sharma, all those things. Okay. Where each corneal ulcer is described in detail, nicely. But then, yeah, this much should do. Okay.
Yes,
And
ma'am.
timolol has no role in your case. Yours is a perforated corneal ulcer. Digital tension should be low. Again, conflicting.
Yes, ma'am.
So you will not give and make the eyeball more hypotenuse. Okay. Along with this, what else will you like to give? You have missed out something topical.
Lubricant.
Yeah, lubricating is not there. Where will the epithelial defect heal from?
Yes, ma'am.
Okay. And
You have no idea how much important lubricants are.
What is the role of doxycycline here?
Ma'am, perforated corneal ulcer, no? So it is a severe ulcer. That's why.
No. Role of doxycycline in any corneal ulcer, what is it? Anticollagenase, correct.
Correct.
Okay.
Okay.
So your collagen.
What is a definitive treatment?
For which one, ma'am? Like
Your case. You are giving all this. Okay, I'm not saying no. Perforation has occurred.
Okay.
So what is the definitive treatment?
Surgical, ma'am.
What surgery?
Ma'am, graft placement.
Penetrating keratoplasty.
Penetrating keratoplasty. Okay. So when you are asked things, you directly jump to a surgery. Don't tell surgical and make them ask you which surgery, all that. Okay. So you tell whatever you feel like. The definitive is, sir or ma'am, I feel that it is penetrating keratoplasty. Be confident in telling that.
Okay.
Then if they ask you this side, that side, you tell why you told PK. Okay. Why did you tell PK? Why not DMAC, DSEC? So many other things are there. You told, okay, now you've told I want to do a penetrating keratoplasty for this patient after the probably active phase, some resolution after the conservative management, and let the patient also plan for the surgery. Okay. You got one donor also, everything fine. Yeah. No, next what? You told PK, and I am saying why not dissect, DMEC, so many other better, nice corneal surgeries. Why not that?
Ma'am,
The basic principle for other surgeries.
Prognosis would be better.
No. Let's come down to the layers of cornea. Okay. In penetrating keratoplasty.
Hello.
Yeah. Can you hear?
Hello.
Yeah, I can hear you.
Ma'am,
yeah, can you hear now?
Yeah, I can hear you, ma'am, now.
Very good. So I'm asking you, basically in penetrating keratoplasty, like what are you removing? Which is there any layer that you're not removing in the cornea, or you're taking the entire thing out?
Ma'am, you're leaving behind.
What are you leaving behind? Penetrating keratoplasty. Can you hear me, Raksha?
Yes, ma'am. I can hear you, ma'am.
Yeah, good. Vaishnavi, Manasa, everyone. Yeah, full thickness. So you have a corneal ulcer, which is involving your full thickness, na?
It is better to do
Penetrating
peeking.
keratoplasty. Okay. So if you will do DMAC, dissect, you're leaving behind some amount of cornea. Then what's the fun in doing it?
Yes, ma'am.
Simply for the sake of surgery, you should not do, no.
Yes, ma'am.
There has to be an aim while you're doing something. Okay. So because all the layers of the cornea are involved, I would like to go for a penetrating keratoplasty. Simple.
Yes,
Okay.
ma'am.
Okay. Very good. All the people in the chat, nice. Very nice. Anything else? Anything else you want to know? Think we have already, yeah, it's almost 8 now. Yeah. Others, Raksha, what is your next slide?
Ma'am, diagnosis.
Okay, bacterial corneal ulcer, mostly staph aureus, being infective organism. See, when you write the diagnosis, firstly, again, mention the eye.
Okay, left.
Okay, left eye. I was not there during the history part, okay. So I really don't know which eye you have told. I mean, obviously examination I was there, but then yeah, you have to make sure that all the examiners, see, sometimes you know what happens in your actual exam as well. The examiner might be having breakfast with your HOD somewhere, and you will be presenting to the second examiner, and then they'll come and they'll sit in between your case and they'll also start asking. So when your diagnosis like this, who will get to know? Okay. Correct, na?
Yes, ma'am.
So you have to tell which eye, right eye, left eye. Okay, what was the right eye diagnosis and what is the left eye diagnosis? Okay, so both of the things. If there was nothing in the right eye, you tell right eye normal or no abnormality detected, whatever. Okay, and the left eye, you should always write ODOS like that only in the same order. Okay, and then you are telling bacterial corneal ulcer. Okay, full thickness. You make it a little flowery and nice. Okay.
Full thickness, perforated.
Yeah. Perforated cornea. There is nowhere you have written perforated.
Yes, ma'am.
Correct, na? So you have to make sure that your diagnosis tells everything. If the person doesn't hasn't listened to any of your case presentation, also should know what did you talk about this much time? Okay.
Yes, ma'am.
So make your diagnosis like that. You tell about perforated corneal ulcer at this quadrant, or with extending from this clock to this clock, whatever. Like as I told you that time. So I don't think I should repeat it. Okay. So make sure you're telling it that way, so that not like epithelial defect. This don't tell all that in detail. That is examination. When you're telling, just make sure they get to know what the thing is. Okay.
Okay, ma'am.
You can rewrite this little in the next PPT and send it to us. We'll share it on with all the participants. Okay.
Okay, ma'am.
I think we're almost done. Any more questions? Anything you can please write to us. We'll forward the questions to the concerned faculty and get you back. Okay, we are extremely sorry. Okay, we'll try to get Rajratna ma'am again sometime soon. But this was definitely not in our hands. Okay, the Chennai storm and everything. So I really hope you people did not feel very disheartened with the presentation today. Sincere apologies. But yeah, I hope you gained something from this. Every one of you. Okay. Thank you. Thank you, Neha. Thank you, Raksha, for preparing